Good morning from the Pituitary Network Association. I would like to introduce our webinar this morning, Nutrition Endocrine Connection Out of Chaos into Balance with Carmina Cuilty-McGee. She is a registered dietitian, clinical nutritionist, and licensed esthetician in private practice, specializing in an integrative mind-body approach to working with endocrine issues. Ms. McGee received a Bachelor of Science degree in Nutrition and Dietetics from Cal Poly, San Luis Obispo, and earned her master's degree in Nutrition from California State University at Northridge. She has had extensive training in the area of functional medicine, specialized training in working with PCOS. She is certified lifestyle educator and certified intuitive eating counselor. Early in her career, Ms. McGee worked as a vocational rehabilitation counselor for the state of California, which provided extensive experience in counseling those with mental and physical disabilities. She has consulted on development of a television healthy cooking program and contributed her expertise on nutrition and skincare to the recently published book 101 Optimal Life Foods by author Dave Grotto. Carmina is a member of the Academy of Nutrition and Dietetics and of the Dietitians Integrative and Functional Medicine Practice Group. A core focus in her practice and expertise is in guiding patients to create neuroendocrine balance through improved nutrition, supportive lifestyle practices, a mindful approach to eating, self-care, and living. Conditions she works with include polycystic ovarian syndrome, thyroid conditions, insulin resistance, diabetes, and gastrointestinal disorders. She works collaboratively with a wide variety of healthcare practitioners, consults to an endocrinology practice, and has a specialized expertise in skin health, an issue in many endocrine disorders. Ms. McGee's practice is located in Ventura, California, and you can learn more about her at www.carminamcgee.com. We'll get started in just a minute.
Okay, thank you, Tammy. I'm so pleased to be here with everyone this morning who is attending the webinar. And I just would like to say that the material I'm presenting today is excerpted from a chapter that I authored for the just released book, The Hormone Factor in Mental Health, Bridging the Mind-Body Connection. All of the references, in fact, that I'm using today can be found in that book. I didn't include them in the presentation today. The book will be available in the UK next week and in mid to late October in the US. And I'm really thrilled to have been included as a collaborator on this project. And like my fellow authors, we are all passionate about improving the health experience and outcomes for all patients struggling with any aspect of the neuroendocrine issues. So I just want to touch on what we're going to be looking at today. We only have a short time, so we really are only going to barely scratch the surface. And what I really want to do is give you a snapshot of some of the connections between nutrition and the work directed by the pituitary gland. So we will be touching on the role of nutrition in production of hormones, neurotransmitters, and neuroendocrine conditions. Also a little on the impact of the gastrointestinal system on the neuroendocrine system. And we'll explore the interaction between excess weight or obesity, neuroendocrine involvement, and healthcare practitioner attitudes. Specific conditions and treatment approaches used by the registered dietitian nutritionist will also be discussed. So let's just start with a concept in science called homeostasis. This is really a word for the body trying to regulate itself through various sensing, feedback, and control mechanisms. So it's always trying to reach some kind of balance. And the endocrine system works under this homeostasis or homeostatic control, but so does the digestive system and the nervous system. I like to think of this as a car analogy. In our bodies, we have a series of accelerators and brakes. And in order to control our speed in traffic conditions, we have to use those accelerators and brakes. And that's also true with hormones that course in our bodies, because they're really just chemical messengers. So these chemical messengers are called hormones and neurotransmitters, and they're kind of like the cars on this freeway. Each car is going to a unique location, and as long as the lanes are clear and everything is in order, the cars get to their destination on time as intended. It's really a communication system. So we have the same kind of sophisticated communication system within our bodies. And it again regulates all of our physiologic symptoms, including the nervous, endocrine, digestive, and immune systems. However, when things go wrong, the communication breaks down and it looks kind of like a pileup on the freeway. The messengers can't get to their destinations and the communication system is interrupted. Then barriers are erected, you have to take detours, and the traffic is rerouted until everything can be cleared up and the communication system is restored and back in balance. But sometimes it doesn't go back into balance, and in our bodies this often shows up as some sort of disease process. So let's start our exploration of food. One of the ways in which the body communicates is through food. Food is actually information. It provides information from a sensory perspective like smell, taste, texture, and this information is relayed to the brain. And in doing that, the communication link has already started. So let me just illustrate that for you with a really simple example. Have you ever held a lemon and experienced your mouth watering? Now you might take just a second right now to try that. Just bring up that lemon and just see if you don't get a little bit of watering of your mouth. I'm actually experiencing it right now. It happens every single time. And this is because we have just such powerful communications between our brain and our perceptions. And so even though you don't have the real food in front of you, you get a tangible response from your body. So let's start looking a little bit more at nutrients. One of my favorite functional medicine scientists, Dr. Jeffrey Bland, who is one of the foremost experts in an area called functional medicine, says that how the nutrients from food are used really depends on each person's genetics, their individual biochemistry, their personal health history, and their unique life circumstances. So there are no big box solutions or one-size-fits-all solutions for us. I'd like to visit the genes a little bit because they're very interesting, the genetic component. The Human Genome Project was an international research effort to determine the sequence of the human genome and identify the genes that it contains, kind of an unpacking of the genes, if you will. It formally began in 1990 and was completed in 2003, so this is, in scientific terms, rather recent. The work of the Human Genome Project has allowed researchers to begin to understand the blueprint for building a person. So as researchers are learning more about the functions of genes and proteins, this knowledge is already having a major impact in the field of medicine, biotechnology, and life sciences. And honestly, we've just touched the tip of the iceberg. In fact, there is a whole new field that has emerged in nutrition that's related to the nutritional impact of genes, and it's called nutrigenomics. It's the study of the effects of food and the food constituents on gene expression, or what your genes are going to do with that. So one of the findings of this project is that genes can be turned on or off depending on the message received. Now remembering that food is offering information and messages. So let me give you an example. Type 2 diabetes, which probably most of us know somebody who has it, or perhaps we have it ourselves, has a strong family component. So if there's a strong family history of type 2 diabetes in your family, there's high risk for developing it. However, with this new information from the Genome Project, what we've learned is that if you send all the wrong messages to the body and you're at risk for developing this, and that would be by eating poor quality foods, being inactive, making poor lifestyle choices, and other factors that affect this, they turn the genetic switch on. Turn on the diabetes is what happens. But the same person with the same risk factors familially can avoid developing diabetes if they don't turn on any of the switches. If they are physically active, they eat a diverse and nutrient-dense diet, they make good lifestyle choices, they're physically active, their stress is managed, and so forth, it is highly unlikely that they will develop diabetes because they haven't turned on the switch. And diabetes, which we'll be talking about a little bit more, is considered a nutrition and lifestyle disease. And it's lifestyle and nutrition that's the first line of therapy to bring it under control, and in some cases even to reverse it. So that's what the genes are capable of. So this is just a little illustration to show you that what the genes do is they take information and they are directed to do something with it, like make protein. So now I'd like to get a little closer look at food. And we're going to look at what we call the macronutrients, or the 3 essential nutrients that every single body requires. Every single one of these large groups, the proteins, the carbohydrates, and lipids, provide us with energy in the form of calories, with vitamins, and with minerals. We can't access those components, however, until we've mechanically and chemically broken down that food into smaller components, so that it can ultimately be transported into and through the bloodstream. So I'd like to look just a moment at the micronutrients. These come from the macronutrients, and they are simply vitamins and minerals. Micronutrients are a substance that usually we require in trace amounts for normal growth and development. So just very small amounts are needed. Vitamins are essential organic nutrients, but most of us cannot make them. Or if we do make them, we make them in insufficient amounts. So we mainly have to obtain them through food. And when we don't get enough food that contains vitamins, that is vitamin rich, we can get vitamin deficiency disorders. And the consequences of vitamin deficiency disorders is it starts to create that freeway pileup that we showed earlier. So minerals are also these little inorganic nutrients, and they also play a key role in ensuring health and well-being. You might recognize them as chromium and zinc, magnesium, calcium, sodium, copper, iron, selenium, and fluoride. These are all kind of those little M&M looking things represent them. But here's what's really important to know about both vitamins and minerals. There is no single food that contains all of the vitamins and minerals we need to take. So therefore, it's critical that we have a balanced and varied diet so that we can get all of those constituents from a variety of foods. So let's go back to the macronutrients and take a closer look. Let's start by looking at carbohydrates, which are primarily found in plant foods, and these are sugars and fibers. The starches and sugars break down into glucose, or what we call blood sugar, because sugar is providing an energy source for all the cells throughout the body so that they can perform whatever function they're going to do. A way I like to think of it is the cells are a car and the glucose is the gas you have to put in your car to get it going. They are a big player in blood sugar control. And fiber, actually, from plants, even though it doesn't directly affect sugar by making it go up and down, it does help to stabilize any sugars that come in, and it's important to the gut health. And we're going to see in a moment why gut health matters. But we do affect the blood glucose through these regulating hormones called insulin and glucagon. So from a hormonal perspective, the carbohydrates are having a big impact on those two. Next, let's take a look at protein. So the body is actually able to make its own proteins from these little building blocks or construction blocks that we call amino acids and peptides. It's pretty good at doing it. There are a group of amino acids, however, called essential amino acids that we can't make. We have to take it in from a food source. Some of them we're going to look at a little bit later in this presentation. But here's some of the importance of protein. Protein is involved in the manufacture of hormones and neurotransmitters. It also is involved in the manufacture of enzymes, which we need. And it's required for the manufacture of blood, for growth of our body, for repair of muscles and other cells like bones. You need to have protein in order to make bones. So let's just move to our next macronutrient. And that is the group called lipids, or we might know them as fats. And what we're looking here is one particular fat, which is called cholesterol, and most people are familiar with that term because usually they're worried that it might be too high. And there's a lot of treatment for cholesterol. But let's look at what else cholesterol does. It has some very important jobs. First of all, it helps to make the outer coating of cells. So every single cell in your body contains cholesterol. It makes up bile acids that work to digest food in the intestine. It also allows the body to make vitamin D and hormones like all the ones we see up above. Progesterone, estrogen, testosterone, which are sex hormones, but also other hormones like cortisol, DHEA, glucocorticoids, and aldosterone. Cholesterol is so important that the body makes it all by itself. It's capable of making it without us eating one drop of cholesterol. So Mother Nature doesn't leave it up to us humans to get it just from diet alone. So even if you ate a completely cholesterol-free diet, your body would make approximately 1,000 milligrams to help it function properly. And I'm not suggesting you cut cholesterol completely out of your body at all. But it's just, I just want everybody to kind of see how this comes about because there's so much focus on cholesterol coming only from food, but the truth is most of it is coming from our bodies. So it's a really elegant process that the way it's made. And let me just show you a very interesting little pathway. And you can see how this cholesterol, which is up at the top, is broken down into all these other things and kind of the molecular and chemical process it goes through to have that happen. However, cholesterol isn't the only fat or lipid that we need. And I just want to point out a couple of other things that fat helps with. Fat contributes to the development and function of the whole central nervous system. All cell membranes we talked about have cholesterol as a component of their structure, but we also have another important fat called DHEA, which comes from fish oil. It's an omega-3 fatty acid. Doxohexanoic acid is the fancy name for it. And it's found in the brain. It's essential for proper brain function, and it's being widely studied right now, especially for effects on depression. And I also want to add a little note here about DHEA and women, because when women are pregnant, they will donate DHEA from their brain to the fetal brain development. So if women are not well stocked on their DHA, it may cause problems for them later. After the pregnancy, for instance, there are some who are exploring whether a lower DHEA level might be involved in postpartum depression, for instance. So this is an important constituent, and this can only be found in fish and in our human brains. So the next thing that lipids or fats do is that they insulate nerve cells in the myelin sheath. That's that sheath that covers all of our nerves so that we're not in pain. And about 80% of that covering is fat. And so conditions that you might be familiar with where that myelin sheath has been stripped away and causes a lot of deterioration are neuropathy, multiple sclerosis, and Guillain-Barré syndrome. So fat gets a bad rap, but in healthy forms it really is an essential nutrient, and it can also be essential for good heart health when you choose the right ones. So here's your brain on lipids, I like to think. I found this illustration and I just loved it because I think it really shows a beautifully functioning brain when everything is working well and all those fatty membranes are happy. So now we're going to move into looking at nutrients and neurotransmitters and all of their connections. Now, we're not going to go through every single neurotransmitter because there are many of them, but we're just going to take a couple of examples. So let's start with the inhibitory neurotransmitters. These are calming neurotransmitters. Most of you will be familiar with serotonin, which is a rather well-known one. And serotonin has a lot of really important jobs it does. It's involved in the regulation of learning. It helps regulate our mood and our sleep. It's involved in vasoconstriction. It might have a role in anxiety and even migraine headaches, vomiting, and appetite control. And we'll see that a little bit later. Now, GABA is another calming neurotransmitter, and its job is to calm and reduce the activity of neurons. So I think of it as a mother calming its upset child, and it's going, oh, now, just calm down. And it's also involved in processes where neural activity is reduced, such as anxiety reduction. So it helps reduce our anxiety. It calms us down. It helps with the release of tension. And when serotonin drops, GABA will actually compensate for a little while. And I think of that in the analogy of serotonin being the bank account and GABA is the ready reserve money for if you go into an overdraft situation. So if we look at the serotonin pathway, you can immediately see, if we start at the top there where the proteins come in, are broken down in the stomach acid, you have to have the presence of vitamins and minerals. Zinc, B1, and B6 are noted here. And then it turns into L-tryptophan, which is an amino acid, because proteins, remember, break down into amino acids. And then we have another group of vitamins and minerals that are involved to help it translate and turn into something else, which is 5-hydroxytryptophan, and more minerals and more vitamins, and ultimately it becomes 5-hydroxytryptamine or serotonin. So once again, you can see the importance of food, and in this case, these micronutrients being cofactors in order to help the production of this very, very important neurotransmitter. So the next group are the excitatory neurotransmitters. If the other ones were calming, these are the ones that cause excitation in the brain. They're also called the catecholamine group. They are made up of dopamine, Nor-epinephrine, and epinephrine, also known as, oh gosh, what's the other name we used to call it? Adrenaline. So I wanted to just use an example of caffeine to show you kind of what happens, because caffeine gets involved with these excitatory guys. And it causes an increased neuron firing. So the pituitary gland senses this activity and thinks there's some sort of emergency. So you drink that cup of coffee, you think you're having an emergency, it starts to release hormones that tell the adrenal gland to produce this epinephrine, or we also call it the fight or flight hormone. And then a number of things start to happen in your body. You're probably not even completely aware of these, but your pupils start to dilate. Then your airway will open up. That's why sometimes when people are having a severe asthma attack, they're given an epinephrine shot. It opens them right up. Your heart starts to beat faster. The blood vessels on the surface constrict to slow blood from any cuts and to increase blood flow to the muscles. Blood pressure rises. Blood flow to your stomach slows down, so it shunts it off and doesn't send it to the stomach, sends it to the arms and legs and other areas. Then your liver starts to release sugar into the bloodstream for extra energy. Then this one you might really feel, your muscles start to tighten up and you're ready for action. So this explains why after you consume a big cup of coffee, your hands might get cold, your muscles get tense, you feel excited, your heart beats faster, you think you can work better. And really what's happening is you're having this experience of your brain believes there's a saber-toothed tiger chasing you, and you are getting ready, your body is getting ready to run for its life. So here's the way I like to think of the neurotransmitters. So let's look a little closer at them. Dopamine, which is a neurotransmitter, has a lot of things that it does. So it's involved in sleep regulation, in mood, in attention, in learning, in cognition, in motivation, and in punishment and reward. A person, for instance, with schizophrenia may have an overactive dopamine system. So dopamine antagonists, or things that help to turn down the dopamine activity, usually will help somebody with that kind of a condition. Now, dopamine is also something that people that do drugs are probably not aware of, but it's in action, especially something like cocaine. It can alter the dopamine function. And it depends on which drug you're taking, which dopamine receptor it's going to affect, stimulate, or block. So some time ago, I remember reading in some of the medical literature the example of somebody who's in Las Vegas playing the slot machines. And when you're playing those slot machines and you win, there's a whole bunch of things going on. There's lots of bells and lights and also the excitement of having won, a little jackpot. And that sends a huge dopamine rush to the brain. And so it works on this reward system. So again, people start wanting to experience that reward again over and over, which is similar to what happens when taking some types of really addictive drugs. This is one of the pathways that it works on. Nor-epinephrine and epinephrine are also neurotransmitters, and they're responsible for some of the reward system information going on in the brain, but it stimulates alertness and arousal, which we also call fight or flight. And you can see in this picture that one of the dogs is in fight mode and the other one is in flight mode. So it just kind of illustrates this concept. Okay, next we're going to move on to one of those essential amino acids that we talked about earlier when we were looking at protein, and that's phenylalanine. So this is an essential amino acid, again, that we can't make. We have to get it from food. And it's a very important one. It's required to make tyrosine, which is another amino acid, which is involved in making that catecholamine group of neurotransmitters, the dopamine, norepinephrine, and epinephrine that we just talked about. So you've got to have this phenylalanine. And if it's deficient, it can cause depression, decreased alertness, it can affect memory, and it also can affect a loss of appetite. Another really critical essential amino acid is tryptophan. And this is a precursor to serotonin, so you have to have tryptophan in order to make serotonin. And it affects our mood and behavior, it affects our ability to sleep, it affects anxiety and appetite again, and it's a precursor to melatonin, the hormone that helps us to sleep. So this is what it looks like. You need to have food, a protein source of food, that contains tryptophan. Most of you will be familiar with Thanksgiving and eating turkey, and it helps with this. But really, any proteins will have tryptophan, any animal proteins especially. So tryptophan turns into serotonin, and then serotonin helps to make melatonin. And here's a little bit of a different view of that, so you can see how they all work together. You can see the serotonin, noradrenaline, or norepinephrine in this view, and dopamine. And you see how they all kind of work together. None of the work that hormones or neurotransmitters do is linear, ever. It always works kind of in a web-like function, very much like you're seeing in this particular view. So let's talk about nutritional deficiencies, because they can lead to neuroendocrine balance. And these are the people that are at risk. People who are chronic dieters, chronic weight loss dieters, are often at high nutritional risk. Very low starvation types of diets. A very recent one was, which I think is now going out of vogue, was the HCG diet, which was using a hormone called HCG that is mostly found in the urine of pregnant women and supposedly is supposed to help melt fat. But the truth is that that particular diet also requires that you eat only 500 calories a day. So in reality, it's a starvation diet. So of course, weight's going to be lost, but it's also a huge stressor on the body and definitely puts people at risk for nutrient deficiency. In fact, lots of those folks were finding themselves losing their hair and nails getting soft and breaking and so forth. Anybody who restricts an entire group of foods, and those with eating disorders like anorexia or compulsive overeating or binge eating or bulimia are also at risk. Basically, eating a poor quality diet of any kind. I do want to give a little example of this. Many folks who choose to follow a vegetarian diet often equate that with just not eating any animal products, but they will happily indulge in tons of processed foods, and as long as they don't come from an animal. And these foods don't really have very much nutritional density or quality. In fact, they can make your health quite poor very quickly. On the other hand, if you do a smart plant-based or vegetarian diet, you can get everything that you need. So it's really the quality of the food that you're bringing into the diet that's really important. And also, if you have any condition that impairs your food intake, or you have gastrointestinal impairment of any type, people who suffer from gastroesophageal reflux, for instance, are put on many antacids, and those antacids actually interfere with your ability to digest food. So that's an issue. We also have people that have malabsorption issues, people with Crohn's disease or irritable bowel syndrome, or maybe they're taking medications that, you know, kind of cause some distress in their GI system. So here's the deal. You are what you eat, what you digest, and what you absorb. It's not enough just to eat the food. Your body has to be able to break it down into those smaller pieces, and then it has to be able to transport it so that that whole communication system is working and nothing gets impaired, and so we don't end up with that freeway pileup situation. So now let's look at some neuroendocrine imbalance related conditions. Now, many of you that probably visit this site may be more familiar with looking at things related to pituitary tumors or acromegaly or other conditions like that. But these conditions are also involved, the ones I'm going to present here to you, with hormone and neurotransmitter imbalances, all of which are being directed ultimately by the pituitary. So the first one is a condition called insulin resistance or prediabetes. And this particular condition kind of has a spectrum. So it can be very mild, and then it keeps building or worsening. Pardon me. And it can develop into diabetes if it's unchecked. Another condition is our thyroid disorders. Another is polycystic ovarian disease, or PCOS, and also obesity. And there's others, but these are some of the key ones. Now, imbalances can affect our appetite regulation and eating disorders. So in this picture, we see this gentleman with a very big appetite eating this ginormous sandwich. And in the other, we see a young girl who's stating, I'm not going to eat. I will not eat anything. So maybe she's not hungry, maybe she's struggling with an eating disorder. But in any case, their appetites are being affected by these imbalances. These imbalances also impact and affect depression and anxiety and can cause them or worsen them. So let's move on to the next section, which is the gut. And what's the gut got to do with it? Well, a lot. A healthy gut optimizes the role it plays in the production of hormones and neurotransmitters. If you don't have a healthy gut, you're going to have trouble making hormones and neurotransmitters that are critical to your health. And why is that? Because the gut is a second brain. Now, Dr. Michael Gershon, who's a physician and a brilliant neurobiologist, He is an expert on gut function, and he wrote this wonderful book called The Second Brain, a groundbreaking new understanding of nervous disorders of the stomach and intestines. And let me tell you that this book sat on in my bookcase for a very long time before I ever cracked it open because it just seemed so dense. But once I started reading it, I realized its incredible brilliance and how important this information is. And I believe, my opinion is, that every physician and nutritionist should absolutely read this book because there's a lot of information in here that relates to health. So here's some interesting things about the gut. One that may surprise you is this. Over 95% of the body's serotonin is stored in these EC cells called enterochromaffin cells that are found in the stomach, they're in the small intestine, and they're in the large intestine. 95% of that. So that's really kind of where the serotonin is also being, it's involved in the manufacture and the storage. So this is our storage depot of serotonin, not the brain. The small intestine may have over 100 million nerve cells, roughly equal to the number of nerve cells in the whole spinal cord. When I read that, I found that to be quite stunning. Now, we looked at tryptophan a second ago, and we know that tryptophan is a precursor now to serotonin. So if you have a diet that's deficient in tryptophan, then you reduce how much serotonin you have in the bowel. And if you can't make serotonin from the food you eat, then your body is going to cannibalize you to get it. It will break down your own protein. And not just the protein in your muscles, but the protein also in your organs. It will go get protein wherever it can. So again, the need to eat high-quality proteins and enough of it in the day is critical. Appetite hormones are also found here. We also find appetite hormones in the pituitary and the hypothalamus. But I just want to point out one little thing about the gut. If you've ever had that kind of nervousness in your stomach, that feeling in the pit of your stomach, or had this gut reaction or something that just went right to your gut, that's not your imagination. That's actually the nerve cells in action. They're having a response. So let's look at just some of these hunger hormones. And there's two of them in particular I want to talk about that are in the stomach. And these are leptin and ghrelin. Now these are relatively new hormones that were just identified in the 1990s, but both of them are linked to hypothalamic and pituitary function, and they're being extensively studied right now because we really need to understand their complete role, both in appetite regulation and obesity. So ghrelin is a hormone that tells us, it drives our hunger. I think of it, grrr, I'm really hungry. And leptin is the opposite signal. It's the signal that tells us we're full or we've had enough, we have satiety. Again, using the car analogy, you might think of the ghrelin as the gas pedal and the leptin as kind of the brake. However, they only work correctly if everything's working correctly, if that highway if that freeway is clear. Otherwise, the signals can become dull, especially with leptin. We find that people that have overweight or are obese often have something called leptin resistance, which is they're making plenty of leptin, but their brain for some reason isn't getting the message of full. And we really don't know very much about that. It's a big area of obesity research right now. So in addition to these ghrelin and leptin hormones in our stomach, dopamine, which we talked about a moment ago, also plays a role in helping us feel satiated and feeling gratified and also having pleasure. It's that thing that, when we have a delicious piece of chocolate or some favorite food that gives us that little rush. Now, serotonin has the action of curbing appetite, but when its levels get low, then it stimulates our appetite, and often that looks like carbohydrate craving. So you want something sugary or you want something starchy, and this is the body's way to actually try to raise dopamine levels. Another hormone player in this is insulin. Insulin is also involved in carbohydrate craving. So when our insulin levels are high, they make our blood sugar eventually crash, and this sets up a situation where the body is now wanting some sugar to bring it back up, but it wants it rapidly and it wants it now. Also, when cortisol, another hormone, is high, It also pushes down our serotonin levels, which again make us hungry. So I know that's a lot of information. Really all I want to bring across is how complex all of these different mechanisms are, and that there's not just one mechanism at play when it comes to hunger and satiety, or any of the other things we've talked about for that matter. So next I want to look at nutritionists, because how do you work with a nutritionist that knows how to work with these conditions? So not all nutritionists have the same qualifications. I personally am a registered dietitian, and I'm a registered dietitian nutritionist now. It's a new designation that our organization has adopted since 2013. Prior to that, we were simply RDs. And the reason it was adopted is because people didn't realize that registered dietitians are nutritionists first and foremost. The public perception was that a nutritionist was a different entity than a registered dietitian. So in order to become an RDN, you have to have a minimum of a bachelor's degree from an accredited university or more education beyond that. But there is some aspect of an internship or equivalent before you're even allowed to sit to take the examination. And the examination is very rigorous, so you must pass the examination in order to have the title of RDN. There is another body of nutritionists called Certified Clinical Nutritionists. They're very comparable in terms of education, experience. They also have to sit and take a test to become certified. And it can be a little bit confusing because there's lots of people using permutations of that certified nutritionist thing. They might be a certified nutritionist, which is meaningless. So what I say is this: anyone else, caveat emptor, buyer beware. Be sure that you select somebody to work with who really has a strong educational background and understands anatomy, physiology, and so forth. So let's talk a little bit about some of the conditions that the RDN sees, and these are certainly ones I work with all the time. Now, most of these are nutrition and or lifestyle-related conditions. We are looking again at insulin resistance or prediabetes, diabetes, PCOS, thyroid, and obesity. First, I want to just take you into insulin resistance and talk about what that is. So insulin is a hormone which helps our blood sugar get into the cells. If you think of it this way, each cell has a little lock on it, and that lock has to be opened. So the receptor is the lock, and the key is insulin. So insulin comes in, unlocks it, and then the sugar can get into the cell. And if you remember, we said that that blood sugar is the energy, the gas that the car needs to run in order for it to do its job, whether it's to make hair or blood or liver tissue or whatever its job is. Insulin resistance is a condition where the body just keeps making more and more insulin to try to control that, getting that sugar into the cell. It's resisting the action of the insulin, so the key is kind of, the lock is a little bit jammed and the key can't open it. And if this goes unchecked, insulin resistance usually will move into becoming pre-diabetes, and then unchecked becomes diabetes type 2. And once you've developed diabetes type 2, that actually leads to even other conditions, health conditions. Now here are some signs and symptoms of insulin resistance, and I apologize for the blurriness on the slide. High cholesterol, fatigue, constant hunger, the inability to lose weight, cravings for sugar or carbohydrates, fatigue after meals, migrating aches and pains, and upper abdominal obesity, or as I like to call it, belly fat. And again, this is a pre-diabetes kind of condition. So next, let's take a look at diabetes, because sometimes there's actually confusion about this as well. There are two types of diabetes. Type 2 used to also be called adult onset diabetes, but type 2 is now described more as a metabolic disorder that's really affecting our blood sugar regulation, like how well we're controlling our blood sugar. Blood sugar keeps rising, and the body is now making a higher and higher demand for insulin. So you're putting a lot of stress on these cells that make insulin. Type 1 diabetes is different. It's an autoimmune condition that happens when the pancreas aren't able to make any insulin at all. And we used to call this juvenile diabetes. We've changed these names for a couple of reasons. One of them is we are now seeing children, I see children that are 10, 11, 12 years old with full-blown type 2 diabetes. And I'm sorry to say that I see them frequently. We really do have something going on. There is a pandemic around this condition. So diabetes is, the insulin is required to manage the glucose that's converted from the starch and sugar in food. So let's move on to just a couple of little facts. And this is from a 2011 diabetes fact sheet. And so that was as of 2011. In 2013, we are already beyond these numbers. But it was estimated that there were a total of 25.8 million children and adults in the United States, or 8.3% of the population, with diabetes. The ones that have been diagnosed by that time were 18.8 million people, but undiagnosed cases were 7 million people. And I bet it was higher even then. This, to me, is the most frightening of all the statistics that they found. Pre-diabetes, they estimate 79 million people have pre-diabetes. So they're in the pike for completing, for developing diabetes if they turn their genes on to do that and don't do something to turn off those genes and change their eating and their lifestyle habits. Now, only 5% of all these cases are type 1 diabetes. So you can see that the autoimmune portion of it is fortunately a very small part. But that type 2 diabetes is definitely a nutrition and lifestyle controllable disease. And it's at pandemic levels all over the globe. This is not just a problem in the U.S. So these numbers are just for the U.S. It doesn't even count other countries. Next, I want to look at thyroid conditions, because the thyroid regulates metabolism, the way the body uses energy, and affects every single organ of the body. In fact, every single cell requires some thyroid in order to also be able to do its job. Autoimmunity is usually the most common cause of thyroid conditions. So in hypothyroidism, that's a condition where you're not making enough thyroid hormone. This can lead to weight gain and difficulty losing weight. That's just one of the just one small thing that it does. And the autoimmune condition that's usually associated with this is something called Hashimoto's thyroiditis. The second type of thyroid condition is hyperthyroidism. Now this is in most of the cases of thyroid conditions are really on the hypothyroid side. Fewer people get hyperthyroidism. I think it was like 15% or something of the population get this. Or 15% of people who have thyroid conditions have hyperthyroidism. And that is a condition of too much thyroid. And in this case, you get a lot of weight loss, excess weight loss. There's another bunch of things that happen with it. Definitely there's a high risk for nutrient deficiency because of the weight loss, and one of the things that happens is you have very rapid transit, so you tend to go to the bathroom very often, very frequent bowel movements. And Graves' disease is the condition that is the autoimmune-related condition with this, with hyperthyroidism. Famously, Barbara Bush is somebody who had it. Now let's look at this sort of rock star chick here. And this really is a really good chart that actually shows how complex this all can be. On one side you have some of the signs and symptoms of hypothyroidism, and on the other you have hyperthyroidism. So you can see it affects the hair, it affects puffiness, sweating, enlargement of the thyroid, which is interesting because you can get a large thyroid in low thyroid as well as in high thyroid. Heartbeat is profoundly affected. In low thyroid you get slow heartbeat, in high thyroid you get fast heartbeat. In low thyroid you have cold intolerance, in hyperthyroid you have heat intolerance, and on it goes. So this, you can see, affects every single part of the body. And it can be a really challenging one. And for the people that have it, if they're under good care and are getting proper balance in their medications and so forth, and in their lifestyle practices and nutrition, it really helps to manage the condition. Next, we're going to look at a condition called Polycystic ovary disease or ovarian syndrome, or PCOS. And this is a condition that really only affects women. So this is a way I think of it as it's a perfect storm of neuroendocrine disruption, because it's involving what we call the HPA axis, or the hypothalamus, the pituitary, the adrenals are involved, the ovaries are involved, the pancreas are involved, and it's estimated that anywhere from 4% to 10% of reproductive aged women are affected. Many of the women with clinical features of PCOS are believed to remain undiagnosed, and that's why there's such a wide variety on the estimates here, between the 4 to 10%. And part of that is because there's been a lot of disagreement about how to identify, how to diagnose it. So 60 to 80% of the women who have this condition are overweight or they're obese. So one of the problems that happens, and I've seen this personally, is that the 20 to 40% that maybe get missed are missed because they're not overweight, and they may have some of the other features, but perhaps the doctor thinks, oh, you probably don't really have it because you're not struggling with weight. So let's look at the diagnostic criteria. In 2003, because there was so much disagreement, in 2003 there was a conference in Rotterdam, and a couple of big endocrine organizations, the American Society for Reproductive Medicine and the European Society for Human Reproduction and Embryology, reached agreement that if 2 out of the 3 diagnostic criteria that I've listed above are present, 2 out of 3, so if you have high testosterone and or DHEA levels, which are male hormones, or you have menstrual irregularities, which means they're irregular, maybe you have a period once, every few months, or you don't have a period at all, and you're a young woman of reproductive age, or maybe you have lots of cysts on your ovaries, which has to be done by ultrasound to determine that. If you have 2 out of the 3, you are considered to have PCOS. Now, some of the problems, some of the things that we see in PCOS, 2 kind of common signs, and they're not by any means the only ones, are hirsutism. There's also, I'll show you in the next slide, but these PCOS results in hirsutism. It can cause that, in high insulin levels due to insulin resistance, and also to fertility problems. It's a huge issue in fertility. So here's an example of hirsutism, which means excess hair growth, and oftentimes it happens around the face and also in other parts of the body, but women are particularly bothered by it when it happens in the face, as you can see in this slide to your left. Another sign is something called acanthosis nigricans. Now that happens not only in women with PCOS, pardon me, but also in people that just have insulin resistance. You might also notice lots of skin tags in people with insulin resistance. So these are a few signs to look for. So let's move on to obesity, which is now a worldwide epidemic. And here's what I'd like to say about obesity. It's complicated. It's not just the simple or simplistic idea of, just eat less calories and exercise more. When there is endocrine involvement, it is not a simple thing like that at all. And also we have other complications because food is emotional. I work with people sometimes who have almost kind of a religious fervorance about being attached to their ideas about food, and it's just very interesting how food interacts with our emotions on all sorts of levels. But food is also a messenger. We've seen that in the previous slides, and it's triggering a bunch of neuroendocrine actions. I believe what makes it complicated too is there's so much confusing information out there. You can get on Google any day of the week and find 5,000 diets and all sorts of information, most of it is just confusing. There may be some nuggets of truth. There's accurate stuff out there, but there's a lot of really inaccurate stuff. So patients that I see often come in and they are overwhelmed and confused and go, just help me because I don't know what to do. And obesity, as far as I'm concerned, is not just an outward sign of something, but it's a first clue to look at for endocrine imbalances. It's kind of a red flag saying, wow, something inside of me is really out of balance. There are things that aren't working right. So let's look at some of the players in the development of obesity. Sleep is a huge one, and there's been lots of stuff coming out about sleep, lots of studies and information. Here are some of the hormonal and neuroendocrine connections. So going back to serotonin, we talked about it being connected to appetite and that sort of thing, but now it's also connected to sleep. So when you have low serotonin, you are also likely to have low melatonin levels, and melatonin is that hormone that helps us to sleep. And so that can often result in sleep disruption, difficulty getting to sleep, difficulty staying asleep. If your blood sugar is crashing during the night, if it's really dropping down while you're sleeping, you can have a sudden burst of this hormone called cortisol, that stress hormone that kind of wakes you up so that your body doesn't, get in trouble and go into a coma or something. It just wakes you up out of nowhere. People who wake up at night and they don't know why they woke up, they didn't have a nightmare, they didn't have a need to go to the restroom, and then they have trouble going back to sleep. I often will immediately look at what's going on with your blood sugar levels, because that's often the culprit right there, that their blood sugar is crashing during sleep time. Furthermore, when you have poor sleep, you just get a higher level of this stress hormone called cortisol, which then increases your fat storage. It acts as a fat storage when there's too much of it, or you're getting too much of it at the wrong time. The next thing involved in obesity is nutrition, appetite, and the quality of food. So what I mean about the quality of food is the example I was giving earlier. If you eat foods that are devoid of nutrition, they're highly processed, they've really stripped a lot of stuff out. My recommendation to everybody is eat food as close to nature as you can get it. If you can recognize it and recognize where it came from, like a piece of broccoli, you can recognize that's a plant. Or beans, you can recognize that those are a plant. That is much better than eating, I don't know, a pretzel where you have no thought that, oh yes, this comes from wheat. So the quality of the food is important. Why? Because it's giving messages. Remember that. And with appetite, low serotonin will stimulate appetite. Remember we talked about that? And it increases carb cravings. So when we have that increase in carb cravings, we're most likely going to eat carbs because we're craving them. And carbs in the way of sugar and bread, something that's going to rapidly break down. And that, in turn, increases our insulin, which ends up crashing our blood sugar, which makes us hungrier, and it makes us tired. Remember that diagram showing that fatigue is one of the things, like after meals? So then we, get an aversion to any kind of physical activity because we're too tired. And in the end, you get an overconsumption of food and you gain weight. But again, it's not because of a willpower issue. It's all these other hormonal and neuroendocrine factors are going on underneath. The next player I want to talk about is stress. Stress is a big player also. It actually is thought to decrease leptin. Remember that is the hunger hormone that tells us, actually it's a satiety hormone that says, okay, we've had enough, we're full. So when your leptin goes down, there was one study by Tamaya et al. That tested these women and found that when they induced stress, that it increased their intake of comfort foods. But if they had some leptin, it decreased their urge to go and get any kind of comfort food. Comfort foods are often going to be in the carbohydrate family. Again, sweets, breads, that sort of thing. And ultimately it results in overeating and you gain weight because we're not getting the signal. Now, meditation is a very powerful tool to use for stress management. And it's been shown over and over to have really positive effects on those excitatory hormones, the catecholamines, so it helps to calm everything down. So when we're looking at obesity factors, there's really a bigger picture. When we're looking at metabolism, these are the things we're looking at. We're looking at someone's age, their sex, their genetics, their neuroendocrine factors, sarcopenia, which is a thinning of the muscles. We're also all very concerned, it seems, with osteoporosis and osteopenia, which is thinning of the bones. But sarcopenia is the same kind of condition related to muscles. We also are looking at metabolically active fat, at medications, prior weight loss. So we're looking at all of the factors that affect metabolism. And when I say we're looking at that, I'm saying our DNs who practice kind of the way I do are functional medicine folks. Energy intake is another thing we look at. We can say calories, but they're influenced by sociocultural factors, mindless eating, physical hunger drives us, emotional eating, mental health conditions, and medications can influence our energy intake. And activity we have to look at from a sociocultural factor because that can influence our activity levels, as well as physical and emotional barriers and medications. So the simplistic description of, an imbalance of energy coming into the body doesn't equal the amount being expended, and if you just move more and eat less, you will lose weight is overly simplistic. It may work for a small group of the population, but what we're looking at these days is much more complex than that. When a health practitioner, specifically a doctor or nurse practitioner or somebody else other than a nutritionist says to an overweight or obese patient, well, just eat less and exercise more, or just lose some weight, that's really not very helpful. If it were that simple, we would not have an obesity epidemic globally. So people need to be guided and they need to be really helped. Oftentimes those very same patients that are told to just eat less are already on really highly restrictive diets with really low calorie intake, and therefore setting themselves up for nutritional deficiencies and driving everything in the wrong direction and actually making themselves fatter in the process. So this takes us to healthcare provider attitudes. And the information I'm presenting here is from the Yale Red Center on obesity. They issued a report in 2012 on weight bias as being a social justice issue. And when I found this report when I was researching the chapter, this kind of, really kind of rocked my world when I looked at this. I really wasn't completely aware of this, although thinking back, I've seen it in action. So here it goes. In a study of 400 doctors, 1 out of every 3, or 1/3 of them, listed obesity as a condition to which they respond negatively. In fact, they ranked it behind drug addiction, alcoholism, and mental illness, so it's very low on the totem pole of concern. They associated obesity with non-compliance, with hostility, dishonesty, and poor hygiene. Lots of judgment there. The self-report also studies doctors that view obese patients as being lazy, lacking self-control, again being non-compliant, unintelligent, weak-willed, and dishonest. The weak-willed one really gets me because, as you've been able to see from the earlier slides, sometimes it's those hormones and neurotransmitters that are driving the show, not our willpower. Sadly to say, there is more. Psychologists actually ascribe more pathology, more negative and severe symptoms, and worse prognosis to obese patients compared to thinner patients presenting with the same identical psychological profile. And in a survey of 2,449 obese and overweight individuals, 69% said they had experienced bias against them by doctors, and among 52% the bias had occurred on more than one occasion. One example given of bias was the target of being the target of derogatory comments or jokes by doctors, nurses, nutritionists, and other health professionals. And how do they know it? Because they heard the comments and the jokes. And the study also found that when doctors see overweight patients, they will spend less time with the patient, they engage in less discussion, they are reluctant to perform preventative health screenings such as pelvic exams, cancer screenings or mammograms, and in general they do less intervention. So all of us healthcare providers, are responsible for checking our biases and ensuring that they're, not there and removing the judgment, because the consequences of medical bias is that patients are reluctant to seek medical care. They cancel or delay medical appointments. They put off more important preventative health care services. And this doesn't even address the feelings that they must be feeling of shame and humiliation. So the role of the integrative RDN is to provide personalized nutrition care that is involved, where you are assessing, diagnosing, intervening, monitoring, and evaluating all of the things that fall below here. Lifestyle, which includes food, traditions, culture, environment, movement, relationships, sleep, stress, supplements. That is that whole thing. When we talk about lifestyle medicine or lifestyle-caused disease, that's what we're talking about. We also look at core imbalances. We look at metabolic pathways and networks and biomarkers. We complete a nutrition physical in order to get a personalized care plan that's nutrition and lifestyle based. And intercommunication is really, really important when working in an integrative kind of a model. So we need the right team working within the right scope of practice. So the RDN is providing this medical nutrition therapy, nutrition and lifestyle counseling, but when psychological issues or medical issues arise, they need to refer out and work with, if possible, the other people who might be able to help the patient. For instance, in my own practice, I frequently am the catalyst of putting my patients together with a psychotherapist if they're struggling with some kind of an emotional or psychological condition that's actually impeding their ability to make some of the lifestyle and nutrition changes we're looking at. So they get help in that way and another source of support. If I get with somebody who's not working with a physician, I will encourage them to find a right physician because they need to have somebody who's looking out for that. And if a physician is involved, it's really important to communicate with them to let them know what the patient is doing and working toward. This, of course, assumes that the patient is in agreement with this and has signed releases and so forth. However, if the psychotherapist or the physician uncover nutrition issues, referral to an RDN is really indicated. I unfortunately find situations often where, gosh, just everybody thinks they're a nutritionist. Everybody from the hairstylist to the psychotherapist and sometimes doctors. And the truth is that they don't have the same training that we get. It's different. It's a different focus. Some physicians are now doing a lot more and getting trained on nutrition in their curriculum, but that's still new. And unless you have a psychotherapist who's also trained in nutrition and is a dietitian, which we do have some, best probably to refer that out to a nutritionist and help them be part of the team. So through coordinated care and communication, the patient can then receive true 360-degree treatment and help and support to get to their goals of creating a healthier life. So just putting it all together very simply, to move from this neuroendocrine chaos to balance, what we need to do is provide excellent nutrition, psychological, and medical care in an integrative model. We need to have in-depth knowledge of neuroendocrine workings as healthcare providers working with this population. We need to, most of all, listen and respect the patient because they are the foremost experts in their own bodies. And that concludes my presentation for you. I just want to thank you and remind you again about the new book coming out. I'm sure it'll be available on the website because it's really a different kind of book and it offers a new paradigm of working with pituitary disorders from a more integrative approach. Thank you. And now I'm going to hand the
Hi, Carmina. Thank you so much.
To Tammy.
Carmina, hello?
Yes, do I change presenter now?
Oh, hi, yes. No, not yet. We've got a couple questions that some of the listeners have asked I'd like to ask you.
Sure.
First of all, can you mention the doctor name that wrote the book, The Gut is the Second Brain?
Yes, his name is Dr. Michael Gershon, Gershon.
Okay. Okay, and then let's see. How do you know if you have a problem with your body absorbing certain nutrients from various foods?
Oh, well, there are some functional testing things that we can do. One of the ones that I use in my practice is there's actually a micronutrient panel that we can run, and what they look at is what the inside of the cell looks like in terms of your vitamin and mineral and antioxidant levels. And it's a very sophisticated thing. It's in a specialized lab in Texas, and that's a very clear way to see it. But if you can't do that test and you don't have access to it, often you can just see it in your body. Is your hair dull and coarse? Is it falling out? Are your nails cracking and breaking? Do you get infections pretty often, or do you get sick often? Because when your immune system is suppressed, oftentimes there might be a correlation to maybe you're not getting enough nutrition to keep that immune system strong.
Okay. Now, would that also include measuring the neurotransmitters and essential amino acids in that test?
Well, that doesn't, there's another test that I also use in my practice, and there's a few labs that do this, but there is a test where you can look at some of the key neurotransmitters. It's done by something called correlation analysis, because we can't cut open your gut and we can't cut open your brain to actually look at the neurotransmitters. But they've got good data. The particular lab I work with came out of Germany, and they're usually very sophisticated and advanced in what they're doing. And through saliva samples and urine sample and a test that you can do at home, this lab can look at what those levels look like by correlation. And I use this frequently, and it's been an incredible tool. And then what we do to fix it is we do a targeted nutritional intervention. So we're going to make sure that you get a lot of those precursors either through your food or in some cases supplementation, just to get the ball rolling until your body is able to do it because you've changed your diet.
Okay. Okay, great. Okay, then Abby, a 67-year-old hypopituitary male who is asking about a 67-year-old hypopituitary male who had pituitary adenectomy 7 years ago. There's significant tumor remnants that are monitored annually. I takes cortisone 20 milligrams AM, 5 milligrams PM, finds that one side of facial flushing, usually late in the afternoon, and often has exacerbated by strong emotions or excitement. Is there any dietary connection?
I am going to say probably not. And I think what becomes really challenging is when our hormones, like in the case of this person who's lost some of their functioning because they've just had some tissue removed. When you have to start controlling everything from the outside, like when you're having to take the cortisone from the outside to deal with this, or in the case of the type 1 diabetic where they have to take the insulin from the outside, it's really hard to be precise and do it the way that our bodies do it, because our bodies are sending out minute little amounts as we need them. But when we do it from the outside, it's actually a little bit clunky. And I'm so sorry. I wish I had some solutions for that, and I don't. So
Okay.
I'm terribly sorry.
Okay.
But I don't know of any direct nutrition connection for that.
Okay. All right. Ellen says, or asks, she says, I have acromegaly, a pituitary tumor that secretes excess growth hormone. Do you have any patients with this condition? Have you found any diet adjustments that help normalize growth hormone levels?
You know, I don't have patients with acromegaly, and I know I've had the question before, and I did some research to try to find if there's any direct connections. And again, this is a thing where that overproduction of growth hormone is probably going to be best controlled with other medications to help do whatever you can do to slow it down. Now, I will say this, it's still really important to have a high quality diet, and especially when you're getting a lot of growth hormone, you want to make sure that you're not having a diet that's going to increase any systemic inflammation, because you're already having all kinds of hyperspeed things happening in your body. So by having what I kind of refer to as an anti-inflammatory nutrition program, which includes, lots of vegetables especially. Vegetables are powerfully anti-inflammatory, particularly the dark leafy green ones. It's like medicine in a piece of food. So really making sure you're getting abundant amounts of vegetables is just going to be a general way to help your body really be in the best nutritional shape it can be in the presence of this accelerated growth hormone.
Okay. Okay, do you subscribe to eating many small meals to increase metabolism and curb weight gain?
Oh, good question. I don't subscribe to any one-size-fits-all for anything. It depends on your condition. When I work with people that are having reactive hypoglycemia because their blood sugars are going up and down, oftentimes I will recommend that they have more frequent meals, or snacks in between meals, because we want to stabilize blood sugar. And by stabilizing the blood sugar, it does eventually help with the weight gain because of all that stuff I explained earlier with insulin, stimulating carb cravings and so forth. And so once you get that stabilized, it can really help. But everybody's really different. And this is something really important that I want to say about that. Anybody having a blood sugar issue, we're always told that, it's really healthy to have, fruit as a snack. Well, it is, unless you have a blood sugar issue. That's not what I would recommend for snacking, because it does make your blood sugar surge. I'd have your fruit with a meal. It's important to have the fruit, but have it with a meal. And some kind of a lean protein for a snack is probably a better choice. And that does seem to help my patients that are also looking for weight management help.
Okay. Okay, great. We do have a few more questions, but I think we're going to conclude for now, and then we will answer all the questions by email.
Wonderful.
Well, thank you so much, Carmina.
Well, thank you for having me.